is being recorded. Is being recorded and will be available after the session. Please submit questions for our panelists through the Q&A button. We will do our best to answer all the questions at the end of the session. We encourage everyone to complete the survey. This will help guide us as we create future sessions. Today's discussion will focus on learning about RSV, the flu, and long COVID. We are fortunate to have experts on today's panel to guide us through this discussion. We'll do a brief introduction for our speakers, but you'll receive their full bio in our follow-up email. With us today are Dr. Stephen Khedive, President, Medical Staff, and Pulmonary Medical Director for Carolinas Continue Care Hospital at Pineville, and Dr. Aaron Trachis, Pediatric Intensivist at Novant Health. Today, we encourage you to reflect on the information provided by our panelists to provide insight into RSV, the flu, and long COVID, and how we can look to play a helpful role in educating the public about these infectious lung diseases in North Carolina. So let's open up the conversation with some of your questions submitted during registration from the audience. We'll go ahead and start with Dr. Trachis. And Dr. Trachis, as a pediatric intensivist, I'm sorry about that. What vaccines do we need to help prevent infectious respiratory diseases as someone with lung disease?
So for pediatric patients, whether they have lung disease or not, we recommend all the American Academy of Pediatric vaccination and CDC.gov vaccination schedule. Specifically, ones that have to do with respiratory illnesses are DTaP, which would help prevent pertussis, pneumococcal disease, which helps prevent various pneumococcal pneumonias, COVID-19 vaccine, and the flu vaccine. In addition, there's also another treatment that is called Synagis, which is a monoclonal antibody injection that certain infant populations receive to help prevent serious illness from RSV, though technically it's not a vaccination.
Got it. Dr. Khedive, as president of medical staff, what are the latest COVID-19 vaccinations recommendations, and do we need to get an updated booster? And can you explain all the primary differences between the series and the updated boosters?
Sure. So yeah, it can certainly be somewhat confusing, and for my own reference, to brush up on things, I frequently reference the CDC website, which really has evolved over the last couple of years with respect to providing very easy to read and succinct information regarding these vaccines. And in the US, there are 4 different vaccines that are available. Most of us are aware with the mRNA series of Pfizer and Moderna. And there's also Novavax, which is based on an old vaccine technology for those folks that are a little more hesitant in obtaining the mRNA vaccines from Pfizer or Moderna. And obviously, there's the adenovirus vector vaccine that's provided by Johnson & Johnson. So those are the 4 available, commercially available vaccines in the US. I think there is some confusion now with respect to the bivalent vaccine, which just came out in the last 4 to 5 months, which Pfizer and Moderna provide. You still need the primary series of vaccinations. And if you refer to the site, for instance, if it's Pfizer or Moderna, you still need the first 3 vaccines followed by the bivalent. For Pfizer, you would receive the initial one followed by the booster 3 weeks later. For Moderna, it's a week thereafter, so it's 4 weeks instead of 3. And then both of those would have the 3rd vaccine a month later, and then wait at least 2 months until you get the newest bivalent vaccine, which provides more cover, and hopefully provides some cover with respect to more of these recent circulating strains, although that is somewhat debatable in terms of the best coverage. Unfortunately, a lot of my patients in the clinic, I do pulmonary clinic as well, are more hesitant and skeptical now in terms of obtaining vaccines, especially that the prevalence of COVID is less than it was in the last couple of years. However, I still encourage all of them to still obtain these vaccines to prevent some of the catastrophic things that we see with respect to COVID illness, whether they're hospitalized in the ICU or the folks that we see in the long-term acute care hospital setting. So it's still very, very important to consider vaccination if it's right for an individual. And personally, go ahead.
Go ahead, doctor.
Yeah, the advice that I give my patients is that, ultimately it's their decision. I give them all the pros, cons, and benefits. And I think that now we've got a lot of good data over the last few years where it is believed that these vaccines are safe. Now, certainly you can get side effects from any medicine, whether it's aspirin or Tylenol or vaccines. And to date, in the US, they've administered about 700 million doses of these COVID vaccines. And obviously, all the adverse effects are recorded. And the risk of serious adverse events of any of these 4 vaccines is very low, and some of them have different manifestations. So I think there are a lot of options with respect to this, and seeing the flip side of devastating COVID and how it can really wreck someone's life, including the patient and his family. For me, it's an easy decision to suggest vaccination.
Thank you for that, Dr. Khedive. Dr. Tracus, we'll go back to you. How do I know what infectious respiratory disease I have, and do they have different symptoms? I know the question says, when should I talk with my healthcare provider about those symptoms?
Yeah, so it's a little bit hard sometimes to tell symptomatically which virus you have. Usually viruses will present in a similar fashion with just a minor cold in any patient population. However, it can develop into something more serious. The upper respiratory infection is, you would notice the runny nose, cough, congestion, really, and sometimes a mild fever. Once it spreads to the lower respiratory tract, that's when you're going to start having wheezing, respiratory distress with retractions. In kids, we see that a lot. That is the sucking in breaths that you see between the ribs. Nasal flaring, which is the widening of both nares. You might see head bobbing in an infant. You may see color changes in an infant or feeding. Those symptoms are relatively similar throughout COVID, flu, and RSV. Both flu and COVID also can have some GI symptoms, vomiting, diarrhea, higher fever than we typically see with COVID, and more systemic infections, whereas RSV is, for the most part, even in severe disease, just a respiratory infection.
Okay. Dr. Khedive, we'll go back to you, and I know you touched on this a little bit, but do COVID-19 vaccines right now protect against the currently circulating strains?
I think there's always some degree of protection that one would get. Obviously, the newest strains have evolved from previous strains. The current bivalent vaccine has material from the initial COVID strains and then the more recent Omicron variants, and things have obviously evolved from that point forward. I do believe that there is some innate immunity that the person will have from vaccination. So definitely would always still recommend it. So the answer to that is yes.
Thank you, Dr. Khedive. And Dr. Tracus, because we have been talking about this and it's been in the news, who is most impacted by RSV?
So it's really, every person is really susceptible to RSV. It's one of the most infectious, contagious viruses that are circulating around. The people that are most at risk for problems with RSV are those infants that are premature, so born before 40 weeks, well, technically before 37 weeks, those that have chronic lung disease, which can include asthma, chronic lung disease from being premature, cystic fibrosis can play into things. Those with restrictive lung disease, with scoliosis, obesity, things like that. And then also the younger pediatric patients, even if they are not a premature birth, they also are at more risk for complications and hospitalization from RSV. And then on the adult side, I only care for pediatric patients. However, the adults with similar issues, so extremes of age, so greater than 65, and other chronic illnesses like immunodeficiencies, lung disease, obesity, all of those things are going to make them more at risk for complications from the RSV.
Yeah, it's a lot that we need to look out for. Dr. Khedive, can we just go back and talk about if I do get a positive COVID test or I test positive for the flu, how long do I need to stay at home? Because I know that that's been a big issue with people now that they've returned to work.
Yeah, and certainly can be confusing. So again, always refer back to current guidelines on the CDC website. For instance, in a hospital, if someone gets admitted, our policy is to isolate them at least 10 days if they're in the ICU. We will extend that further beyond the 10 days if the person is still symptomatic from a respiratory perspective. If it's on a regular ward, we can limit that to 5 days, depending on the patient's clinical course. At home, the 5-day rule is adhered to or should be adhered to as well, assuming that the person is getting better. And if they're fever-free for at least 24 hours, so they should, stay at home, isolate from other family members for at least those 5 days, wear masks around other folks. If the person, and it's also important to determine the time zero, and usually if someone's symptomatic, you use the day of symptom onset as the first day of isolation for the 5 days. If the person is still symptomatic beyond the 5 days with fevers and various respiratory symptoms, then one should extend that. You can do antigen testing if it's available in your local area with respect to clearing that person from isolation, and you would need 2 separate negative antigen tests 48 hours apart beyond the 5 days. If one of those tests is positive, then you would extend to 10 days at least. So that's a little bit about the isolation. With respect to flu, I think it's a little less strict. From what I've read and what I follow is that it's at least a 24-hour mark from being fever-free, improving from a clinical symptom perspective, and not using any antipyretics, things like Tylenol or NSAIDs like ibuprofen, Motrin relief to mask the fever, and so that would be important to follow that as well. The other thing for COVID, it's also important is to understand if you're not symptomatic, that time zero is the day of the positive test. So that's a little bit different to the symptomatic patient.
Thank you. And I know we're talking about COVID vaccines, but then let's talk to you, Dr. Trachis, about, we've heard that there are some new RSV vaccines in the pipeline. Who would those be for when they start being released?
Yeah, so there is current development of RSV vaccinations for all patient populations, all age groups. However, the one that is closest to being distributed is currently under FDA expedited review, and that's for expectant mothers. And the reason for that is that the mothers would be immunized and then also pass along the antibodies to their fetus, and then that would passively immunize the infant when they are born for several months as well, without actually requiring an immunization. So that will be the next most likely one to come out first.
And Dr. Khedive, as we talk about testing, the question that we have is, how do I get tested for flu when I have symptoms and my at-home COVID test came back negative?
Well, you can get flu tested through any physician office. They have rapid tests in most urgent cares, physician office, primary care offices. So that would be the suggested path to get evaluated. Obviously, some patients land up in the emergency room, and we have PCR testing, rapid again, which is combined with COVID testing, and in some facilities they actually have a combination COVID, RSV, and flu kit, which will do one swab to test for all three. In our institution, locally here, we just use COVID, or we have assays for COVID and influenza A and influenza B. I guess probably because we see less RSV in adults. We do have an expanded respiratory pathogen panel that tests for about 20 different organisms, most of them being viral, a couple of them bacterial. We use that less often nowadays, but we will do that for some of our patients.
Thank you. And Dr. Trachis, a question that we have from one of our people who registered is, my baby was hospitalized with RSV this season. How do parents protect their infants from the virus?
Right, so that would be similar to protecting against any respiratory virus. So the single most important thing is to wash your hands. You want to wash for at least 20 seconds. In pediatrics, we always say to sing the birthday song 2 times, and that will be 20 seconds. You can do that in your head. If there's not soap and water available, using an alcohol-based hand sanitizer is very helpful. The RSV specifically, and most respiratory viruses, spread by droplets in the air as well as on droplets that are on surfaces. So that's why it's so important to wash your hands. If you personally have an illness, a respiratory illness, it's important to cover your cough and your sneeze, not in your hands, so either in a tissue or your elbow or arm. And then if you are able to get immunizations for any respiratory illness, it's important to be up to date on those, even though there isn't a widely available RSV immunization. It is helpful to have immunizations against other viruses, as each time you have a virus, that does kind of knock down your immune system in the respiratory tract somewhat and make you more susceptible to additional illnesses. So recommending all immunizations for respiratory illnesses. And then if you are sick, to also wear a mask if you need to be around other people. Stay home if you are sick, and if you are the parent of a small infant, especially less than 6 months of age or premature or any of those high risk factors, to try as best as possible not to be in any crowded areas like the grocery store, churches, even big family gatherings, and to really minimize the amount of people that you're around until the immune system is a little more robust.
Got it. And Dr. Khedive, has there been any updates in the flu vaccination recommendations, mainly for those that are 65 and older? Any preferential recommendations for those 3 vaccine products?
Well, so flu, obviously, it's recommended that everybody gets vaccinated for flu in terms of adults, especially senior patients. So that really hasn't changed much. And the time to vaccinate that we recommend start around September, October, and that usually provides cover for the next 6 months. So the usual flu season, although you can see patchy outbreaks of flu even in the spring and summer months. I think a lot of our patients don't recognize that, and I think that if they got a vaccine in January or February, it covers them for the entire calendar year, which is not the case. So if we have seniors who are above 65, we'll recommend the high dose quadrivalent vaccine, which is not a live vaccine. There are live vaccines that are generally not used in adults. So we just rely on the supply that's given to us here at Atrium Health from various vendors. In patients who are less than 65, they do not need the high dose vaccine. Obviously, the high dose vaccine is utilized to boost a positive immune response, so that individual has adequate protection cover. It's also important to remember, and patients often say they got the flu after the vaccine, and I think us as providers recognize that that is something that a lot of patients believe may occur, whereas they may just be unlucky enough to contract the infection during the time that they're actually not protected, because there is usually a 10 to 14 day lag period in terms of immunity from the vaccine. And what I tell my patients also to be cognizant of is that even if you get the vaccine, you certainly can still get flu, or for that matter COVID if you get the COVID vaccine, but you're more than likely to not have a serious illness, not be hospitalized, and actually survive from the illness. With that being said, what we also focus in our pulmonary clinic is pneumococcal vaccines, which is vaccination against strep, which is the most common cause of bacterial pneumonia. We have a new guidance for that in terms of providing Prevnar 20 vaccination to those patients that are older than 65. And there's a whole series of these pneumococcal vaccines. And in adults, we utilize Prevnar 20, 13, and 23. And then we have an algorithm in terms of which patients to provide which series of vaccines. But for most folks nowadays, we will give them the Prevnar 20 once. And that's really important for us to minimize the likelihood of any respiratory tract infection.
Thank you so much. This has been a great dialogue, but we're going to open up the conversation to the viewers. Like we said once before, please submit your questions through the Q&A button. We'll do our best to get to your questions. The first question is for Dr. Tracus. And Dr. Tracus, how do, this person says, how do you make a baby comfortable when they have RSV? What symptoms should parents look out for, and what would warrant an ER visit?
Sure. So symptomatic treatment is really what we recommend at home for any patient that has a respiratory illness. So really Tylenol for if as long as there's no allergies, Tylenol for discomfort as well as fever. If they're older than 6 months, ibuprofen or Motrin is also recommended for the same. A cool mist humidifier will help with secretion management and mucus management. When your mucus gets dried out, it becomes a lot thicker and difficult to get out. And in infants and children who have smaller airways, that can cause a real problem with respiratory distress. We also recommend using nasal saline washes or sprays, which they have at any pharmacy, and using suction to help expel the mucus from the patient's airway, since they don't know to cough, and it's a little bit more difficult for the infants and children from that regard. And then, I'm sorry, what was the second part of the symptoms to look out for?
Yes, the symptoms to look out for.
So you should seek medical attention if your child has respiratory distress. So if you notice fast breathing, retractions that I mentioned earlier, which is the sucking in, you can see the ribs kind of sucking in, seesaw breathing with your belly kind of going up and down with your chest, nasal flaring, which is your nostrils widening out with every breath, head bobbing. You may see in infants grunting noises in infants as well. And if you are less than 30 days, if the patient has a rectal temperature 100.4 or higher, they automatically need to go to the emergency room just for an evaluation, because they're more at risk for any type of infection. And if you've had a fever and you're older, 6 months or older, for 5 days or more, you would want to seek medical care to make sure you haven't developed a secondary complication that requires a different treatment.
Thank you. And Dr. Khedive, we've been getting this question a lot. It's a two-parter. One, what is long COVID? And two, what are the treatments for long COVID?
Yeah, so that's a difficult thing to answer. It's hard to define because it's a new problem. And I think if you look at the definition as the CDC puts out, it can really represent a whole multitude of different symptoms affecting different organs. It can affect neurocognitive function. So a lot of patients will complain of inability to think clearly. They sort of live in a brain fog. And I've certainly heard that from a bunch of patients in the office. You can have residual pulmonary symptoms of any kind. Cardiac issues as well. You know, COVID is known to be a cardiotrophic virus that may cause damage to the heart, which fortunately is not that common. So you can get palpitations, chest pain, things of that nature. Also known to cause GI symptoms as well, and also non-specific muscle and neurologic symptoms as well have been reported. So I think a lot more is required with respect to chronic follow-up of these patients in this population group, and then also further studies to determine the extent and nature of this long COVID syndrome. I think there is evidence out there now to suggest that the vaccine series helps prevent this, both as a primary prevention technique with respect to vaccination before COVID infection. And certainly it seems to be favorable in terms of helping this from a long-term perspective in those patients who did contract COVID and suffered the consequences thereof to receive vaccination, which may help reduce these long COVID symptoms. And then obviously managing the symptoms with respect to cough and bronchospasm and things of that nature, and facilitating good sleep and looking for other conditions that may contribute to the symptom complex, which someone else, some of these patients have things like sleep apnea and so forth. So just trying to address all of the issues holistically. I don't think there's any magic bullet to fix it per se, but obviously primary prevention is super important. And hopefully we don't have outbreaks like we had in the last 2 years. Unfortunately, at least in the hospital, we're not seeing case numbers like we did before, but we are still seeing periodic cases. What I find very useful if patients are interested to look at the CDC maps for viral outbreaks. They release annual maps, or actually monthly, weekly maps for influenza, and they have similar things for COVID now, where you can track the local prevalence of these viral infections in your community. And what I tell my patients in the office, if some of them are on the fence in terms of getting COVID boosters, it certainly makes a lot more sense if the prevalence increases in their local community to rethink their strategy with respect to these booster vaccinations.
Thank you so much, Dr. Khadib. And seeing how we're talking about lasting, some of these infectious diseases lasting. Dr. Trakis, a question we have here is, how long does a baby usually have symptoms from RSV?
Yeah, so usually it's approximately 3 to 7 days of illness. You may see some lingering symptoms up to 14 days. And the worst symptoms that you may see are usually seen at the 4 to 5 day mark, although that's not across the board. It is most commonly seen that way.
All right, and we got time for one last question. And we'll just go with Dr. Khadib because this has been something people are trying to tell the difference. How do you know the difference between asthma, COPD, RSV, flu, or COVID? I mean, there's so many things out there right now this season. How can people tell those differences?
Well, so with respect to asthma and COPD, most patients have a pre-existing diagnosis of those conditions. So I think that's where history is important in terms of trying to figure out what's going on with an individual. And certainly patients may have flares of those particular disease syndromes without having a viral infection. Sometimes it's difficult to tell, and then we have to, do testing to confirm that with these nasal PCRs that we use in the hospital and the clinic setting. And then sometimes patients will get features of asthma or COPD in terms of what's labeled asthmatic bronchitis, where the patients will have an asthma type syndrome in response to a viral infection where they behave like an individual who has asthma. And we treat those the same with inhaled bronchodilators and steroid therapy, whether it's oral, IV, or IM, depending on the severity and whether the person is hospitalized at home. And if someone is diagnosed with a viral infection, as most people know nowadays, that there are antivirals for COVID, which do seem to be quite effective. I personally have prescribed Paxlovid quite a bit to patients to outpatients, and it seems to help them substantially. I've heard anecdotally, a lot of my patients have told me even after a couple of doses, they do feel much better with Paxlovid. There's another oral antiviral that seems to be inferior with respect to results, so I usually try and stick to Paxlovid. And with Tamiflu, there are a couple of options that we use as outpatients and in the hospital, probably less effective for that virus than what we see for COVID.
Thank you so much, Dr. Stephen Khadib and Dr. Aaron Trakis. Thank you for this whole conversation that we've had today. Before we conclude this session, we want to share important resources. American Lung Association is committed to supporting those impacted by RSV, the flu, and long COVID. We are proud to partner with organizations like Novant Health and Carolinas Continued Care Hospital to bring awareness to these infectious lung diseases. For more information, visit the websites listed on your screen, and we will include this information in our follow-up email. Like we said, this has been a great conversation. And if you submitted a question that we were unable to answer, our American Lung Association team will get back to you within the next week with the answer to your specific question. Once again, thank you all for attending today's Community Connections. I hope you found it informative. A special thanks to our presenting sponsors, Novant Health and Carolinas Continued Care Hospital. We're grateful for our panelists and for their time, their insight, and their service. Once again, thank you, Dr. Aaron Trakis and Dr. Stephen Khadib. Please remember to complete the survey. Your feedback is important to us. Check your email for a recording of this session and additional resources. Once again, thank you so much and have a wonderful day.